Welcome to The Explainer. Today, we're executing a high-yield transition from biostatistical validity straight into high-stakes critical care. We are specifically targeting the strict physiological thresholds of neonatal resuscitation, including the MR-SOPA protocols and the absolute umbilical access mandate.
Here is our roadmap for today. We'll start with biostatistics and evidence analysis, move into fetal and neonatal assessment, cover respiratory pathologies and hypoxia, break down mechanical ventilation principles, and finally, integrate it all with high-yield clinical cases.
Section 1. Biostatistics and Evidence Analysis. All right, before we even think about executing advanced algorithms, we have to rigorously evaluate the data defining those protocols. This matrix defines our diagnostic strategy. When evaluating tests, you really have to define your objective. Screening for a disease, that requires high sensitivity. You want to minimize false negative rates and capture almost all affected individuals. Conversely, confirming that positive screen requires high specificity. This ensures clinical variance is minimized, and a positive result strictly dictates true disease.
Now, in analyzing study designs, strictly define the temporal direction. A prospective cohort study isolates exposures and observes them forward in time to measure incidence. On the flip side, a case control study looks backward from a defined clinical effect, analyzing past exposures to calculate an odds ratio.
And here is your golden rule for statistical significance. It's strictly governed by the 95% confidence interval. If the interval for an odds ratio or relative risk crosses the number 1, the association is statistically null. Strict adherence to this principle is absolutely crucial to prevent false positive clinical protocol adoption.
Section 2. Fetal and Neonatal Assessment.
Now, we apply those evaluative principles to precise neonatal stabilization protocols. While the APGAR score guides your general assessment at 1 in 5 minutes, immediate action is dictated by strict heart rate thresholds. Analyze the first 30 seconds of life. Warm, dry, stimulate, and clear the airway. If that neonate is term, breathing, and has good tone, they stay with the mother. If not, and the heart rate is strictly below 100 beats per minute, or if there's persistent apnea or gasping, immediate positive pressure ventilation, or PPV, via bag mask alongside SpO2 monitoring is mandated. And if the heart rate drops strictly below 60 beats per minute despite 30 seconds of effective PPV, well, you've crossed the circulatory threshold. That strictly mandates coordinated chest compressions.
Post-stabilization, universal prophylaxis is an absolute mandate. We administer erythromycin eye ointment to prevent gonococcal ophthalmia neonatorum, an intramuscular vitamin K injection to stave off hemorrhagic disease of the newborn, and the hepatitis B vaccine, which must be given within the first 12 hours.
For in utero assessment, we utilize the biophysical profile. Just use the mnemonic "Test the baby man" to systematically sequence through fetal tone, breathing, movement, amniotic fluid volume, and the non-stress test. Remember, scoring decrements here strictly correlate with fetal acidemia and compromise.
Section 3. Respiratory Pathologies and Hypoxia.
When respiratory distress sets in, we must rapidly identify the underlying mechanism. After evaluating the AA gradient in a hypoxic patient, this is literally the most critical diagnostic question you must ask. Is the hypoxia correctable with supplemental oxygen? The answer to this completely dictates your next diagnostic step.
Here is why that dichotomy is so vital. A VQ mismatch, like what you'd see in asthma, pneumonia, or pulmonary edema, generally improves with supplemental oxygen. A right-to-left shunt, however, bypasses ventilated alveoli entirely. Think intracardiac shunts or severe atelectasis. Because deoxygenated blood completely bypasses the provided oxygen, the cyanosis and hypoxia will strictly not correct, regardless of how much oxygen you administer.
This manifests really clearly in respiratory distress syndrome. Premature infants born before 34 weeks lack sufficient alveolar surfactant. This leads to intrapulmonary shunting and a classic ground glass reticulogranular pattern on the radiograph. Management strictly mandates immediate, continuous positive airway pressure, or CPAP, and frequently intubation for exogenous artificial surfactant delivery.
Section 4. Mechanical Ventilation Principles.
When non-invasive stabilization like CPAP fails, we have to escalate to rigid mechanical protocols. Intubation is executed based on strict clinical criteria: failure to protect the airway, or severe hypoxia and hypercapnia that are refractory to non-invasive means. For neurological compromise, you must adhere to the definitive maxim: Glasgow Coma scale of 8 or less, intubate.
Once your patient is intubated, arterial blood gases dictate your adjustments. To fix oxygenation, your PO2, you either increase FiO2 or prioritize increasing PEEP for alveolar recruitment to avoid oxygen toxicity. Conversely, hypercapnia reflects a ventilation deficit. To fix that, you need to increase minute ventilation by up-titrating either the respiratory rate or the tidal volume.
Section 5. High-yield clinical cases. Let's integrate these discrete mechanisms into some high-stakes scenarios.
Consider this presentation. A 2-day-old newborn presents limp and seizing. What are we looking at? Well, a microdeletion in chromosome 22q11.2 causes Dye-George syndrome. This is a thymic parathyroid dysplasia, leading to severe hypocalcemia, which explains the seizures, and an absent thymic shadow. Why are the other typical distractor choices incorrect? Down syndrome lacks hypocalcemic seizures. Severe combined immunodeficiency presents with severe recurrent infections, not tetany. Trisomy 13 features midline defects like a cleft lip, and Wiskott-Aldrich syndrome is characterized by eczema and thrombocytopenia, absolutely not absent thymic shadows.
Another critical diagnostic trap is a premature infant developing feeding intolerance, bilious vomiting, and bloody stools. If you see radiographic visualization of pneumatosis intestinalis, that's intramural air on the X-ray. That strictly confirms necrotizing enterocolitis. This extensive inflammation and ischemia mandates immediate bowel decompression and surgical evaluation.
Ultimately, your goal is to synthesize this data to treat the underlying disease. When standard positive pressure ventilation fails, you have to observe the strict physiological algorithm. If the heart rate strictly drops or remains below 60 beats per minute despite 30 seconds of effective PPV, hemodynamics have collapsed. You enter the compression zone. That strictly mandates a 3-to-1 ratio of coordinated chest compressions to ventilations, 90 compressions and 30 breaths per minute, and the FiO2 must immediately be dialed strictly up to 100%. Endotracheal intubation is strongly indicated here. Now, if the heart rate is still below 60 after a full 60 seconds of coordinated compressions and effective PPV, medical therapy is required. You enter the absolute umbilical access mandate. IV epinephrine is strictly required via the umbilical vein to aggressively drive coronary perfusion. And remember, before any escalation, you must distinguish primary from secondary apnea. Primary apnea resolves with simple physical stimulation. Secondary apnea completely fails to respond to stimulation, strictly reflecting profound hypoxic ischemic depression.
This brings us to your master case blueprint, testing deep integration of the neonatal resuscitation algorithm under extreme pressure. Picture this. A neonate is born floppy and apneic. After warming and drying, the heart rate is 55 beats per minute. The team immediately initiates PPV, but at 30 seconds, the heart rate drops to 50. Now here is the diagnostic trap. Crucially, the infant's chest is completely failing to rise during the PPV breaths. The assessment will aggressively tempt you by highlighting that catastrophic heart rate to see if you immediately select chest compressions, intubation, or IV epinephrine. That is an absolute algorithm violation. You absolutely cannot initiate compressions without effective ventilation first. Out of exactly 5 distinct answer choices, the correct one must strictly force you to select airway repositioning or mask adjustment, the MR-SAPA corrective steps. So always ask yourself before every clinical decision, are you treating the monitor or are you treating the patient? Thank you for joining me on this explainer. Keep studying hard.